to do just a quick overview about diabetic retinopathy in the context of avoidable blindness. So the last talk that in this series was with Dr. Neil Murray, and he talked about blindness and its effect on lives, people, villages, countries, and that when a patient or a person becomes blind, it has an impact not just on them but on the entire family. And he was talking about life expectancy from becoming blind being about 10 years. Okay? If we add in diabetes and advanced eye disease being the cause of that blindness, it drops to about 5 years. If we add heart disease on top of that, it's about 3.5 years. Okay? So contextually, diabetic retinopathy is an indicator of really unwell people. Okay? So let's just start about where we're talking about. Now this guy here, don't know his name, but he's had surgery. Okay? He's had cataract surgery. So for those of you not familiar, cataract surgery deals with the lens at the front of the eye and replacing opaque tissue with clear structures. It allows a patient to see again. So historically, patients have become blind, they've had an operation, and then they can see again. Okay, so just remember that. What we're going to be looking at today is all the way in the back of the eye, here in the retina. Okay, so that's a structure that holds teeny tiny little blood vessels. It's got a whole lot of sensors on it, and it's what creates your vision. Okay, all of the other structures of the eye just focus the light back to the retina. So it's like the sensor on your camera. It's the first layer of the brain, some people say. So it's really, really important. Okay, let's have a wee look at diabetes. We all know, we've heard about diabetes, it's in the media. We probably know somebody who has diabetes. Worldwide, this comes from the IDF, which is the International Federation for Diabetes. This is current data. And Western Pacific is the blue area there. 138 million people currently diagnosed with diabetes. Western Pacific does actually include China and Japan, so we're slightly skewed, but it's a pretty horrific figure. And if we have a look at the top 10 countries with diabetes, let's have a look at that. 7 of them are from the Pacific Islands, and the other 3 are from the Middle East. Okay, so again, remember that. Let's have a look at that top one, Tokelau, 37.5%. So over a third of their population aged over 20, now remember that's the working population, have diabetes. So it's pretty horrific. Some of our good neighbours, the Cook Islands, 25%. So pretty big numbers. Now that's forecast to increase by 46% in 2035. So diabetes has the potential to bankrupt nations. Okay, it's massive. Let's have a wee look at what is diabetes. We know, we've all heard about it, we've got type 1, type 2, what do they mean? So basically type 1 diabetes is an autoimmune disease. It's where the pancreas stops producing the insulin. It's not a lifestyle disease, it's not an obesity disease, autoimmune. The consequences are the same. That's why it's got the same label. Type 2 diabetes, which is what we're predominantly dealing with, is a condition of genetics, lifestyle and obesity. Okay? So basically, if we have a quick recap on what happens with diabetes, is that the pancreas stops or slows down production of insulin. Insulin is what moves the blood sugar from your bloodstream after you've eaten it to your cells and your tissues to be used. Okay? So that's the key that moves that pathway and allows the transition of those blood sugars. So if that blood sugar stays in your bloodstream, it's really toxic. And you get unhealthy blood. So wherever your blood is going, you're going to be having damage, which is why diabetes is so systemic. We have problems with our feet, our kidney, our eyes, our heart, we have stroke, all sorts of things. And I've put some faces up here. It doesn't just affect the elderly. We're seeing a lot more people diagnosed in their teens and in their 20s, okay? So management of it can be pretty tricky. If we look at the Pacific Island context, diagnosis of diabetes can be really tricky because there is no systemic screening tools or program like we've got in New Zealand and Australia for diabetes. So patients are living with this disease in an undiagnosed and unmanaged condition. Let's have a wee look at this lady. Her name is Melly. She's from Tonga. Just have a look at how she looks. Does she look happy? No, she's a pretty sad lady. So Melly is the epitome of a diabetic patient in the islands. Okay. Can you see how many legs she's got? It's just one. Okay. The conditions that she's living in are pretty very third world. Okay. Not everything about the Pacific is what we see on the brochures. Okay. Yes, beautiful beaches, but this is the other side. Dirt floors, manual labour, cooking, and she can't participate. She's still of the working age. So her daughter, who is inside, is doing everything for her. So her daughter is now looking after her. So people of the Pacific, especially Tonga and some of the other islands, are subsistence living. So they cook, they grow, they eat, they sell, they earn. Okay? So think about that in the context of blindness. If you can't do it, who else is going to do it for you? And even if you think about moving around this type of environment with low vision or poor vision, okay? This doesn't really bear thinking about it, does it? I'm really impressed at her wheelchair though. That's really nice. She's done very well for herself there. Very often you see them without any rubber on the rims, they're just rolling on metal. And they have the seat is all frayed out and worn out, so they get the resin chairs that we get here for a tenner, and they cut the legs off and stick the resin chair into it. So, yeah, they're good to go. So this is what a normal retina looks like. Okay, has anyone seen any images like this before? No? Okay, so this is a photograph of the back of the eye. The big white thing that you see here on the left side is the head of the optic disc, so the head of the nerve that takes all of that imaging from the eye to the brain to be processed. We've then got a number of blood vessels, and those are the red squiggly lines that you can see. And this area in the middle here is a really special place. It's called the fovea, and it's a really concentrated group of cells that's responsible for your fine detail, your colour vision, the things that you're looking directly at. So the most precious parts of our eyes are the nerve and the centre bit. Okay? So what happens to the eye? Well, if we think back to our blood, and our blood has got a high amount of blood sugar in it, as it's passing through these tiny blood vessels, that blood is damaging the structure of those blood vessels. So over time, those blood vessels become damaged and they break open and they bleed. And we get pictures looking like this. Okay, so if you remember, that centre bit here was really, really precious. That's where the person has their things that they're looking directly at, their focal point. You have bleeding and swelling in there. You don't see particularly well, okay? Unfortunately, with this eye disease, is that until it gets right into the centre, the patient is completely unaware. They're fine, good as gold, twice as shiny, no problems. So regular screening is not something that enters anybody's sort of world or scope of importance because their vision is fine. Okay. Another example of some pretty horrific eye disease, and this person is one out of our Suva clinic, and a really young lady. Okay, she was in her 30s when we took this. Okay, this was from last year. So again, you can see all of this white stuff. Okay, so that white stuff is what we call exudate or lipid. So it's a fatty deposit. It indicates swelling of the tissue. Okay. Those big red hemorrhages that you see up the top there, that's bleeding that's left the retina and it's coming out into the gel in the middle of the eye. So this person is very close to having what we call a sudden loss of vision. That's where 1 minute they can see, the next minute it's all black. And this is really, really common as well. That's what happens after they've had a sudden loss of vision. We get lots of tractional tissue, which is all that white stuff you can see. That's fibrosed scar tissue in the eye, and then that pulls on the back of the eye and the retina will detach from the back of the eye. So prognosis for these types of patients is really, really poor. Unfortunately, in the Pacific, we have lots of patients presenting with significant disease at their first presentation. So this is what you and I see, hopefully. This is what a person with retinopathy might see. Okay, it's pretty rubbish really. Again, lovely picture of a dog, bad eye disease. Okay, now the difference with this type of eye disease versus cataract surgery is that we can't do a simple operation to make it go away. All right, we can treat it if we know about it early enough to stop it from progressing, but once it's at those stages that I showed you earlier, that's it. There is no solution. Okay, so the key here is about early intervention, early diagnosis, and treatment at the appropriate stage. So this is Dr. Rabibi here, Dr. Bew and a patient, and they are performing some laser on a patient in the Suva Eye Clinic. Dr. Rabibi is a training doctor from Kiribati, and she'll be finished her Masters of Medicine in Ophthalmology later on this year. She'll return to Kiribati. So laser is, as you know, you've seen them in the news, all sorts of uses within medicine, is a really intense beam of light. And we use that on the retina to treat areas of prolific bleeding, to stop the proliferation from occurring and stop the progression of the diabetic retinopathy. Within the Pacific, we have developed a set of national guidelines. I call them national because they're across nations, and we're trying to train everybody to use the same set of guidelines so that within the Pacific, whenever we see somebody, it doesn't matter which country they're in, if we need a second opinion or we need to manage them, everybody's managing them according to the same set of rules. We're comparing apples and apples. The patient's management doesn't change if they change regions. Okay, so this is a fabulous tool. It's been really widely adopted by the nations and by the consultants and the screening team who are using it. And for those nurses and doctors who are perhaps slightly isolated, who don't have ready access to secondary consultants or even a peer review, they've got something that they can go and refer to. This one is specifically developed for the Pacific Island setting and takes into account all of the factors such as accessibility to eye clinics, transport, training of the Pacific. It's the Diabetes Eye Clinic, which we opened 2 years ago in June. This is our training facility, so all the students come here. Currently we've got a postgraduate certificate course in diabetic eye care, which is being offered to Pacific Eye nurses. And this is where they come to train, and they learn about the Pacific guidelines. They learn how to identify diabetic eye disease and identify the risk factors which will make that eye disease progress to vision loss. So if we look at the risk factors, duration is a massive one. Okay, the longer you have a disease, the more likely you are to get complications from it. Okay, so if we don't know that we have the disease, or if we're not diagnosed and we're not managed, then the duration becomes a little bit questionable. So we're not sure how long people have had it. So that's a bit tricky to manage. But with a few probing questions, you can kind of figure it out. Their blood sugar levels. The higher the blood sugar, the more damage it will do. The lower the blood sugar, the more controlled the patient is, the less damage will happen. Okay? So the blood sugar control is managed by oral drugs, injectable insulin, and lifestyle and dietary changes. There are some massive barriers for patients of the Pacific around access to drugs, around access to screening for diabetes. So we've got two big problems there. Blood pressure is also a massive risk factor for diabetic retinopathy and its progression. The higher your blood sugar goes, your blood pressure, the more quickly you're going to have bleeding inside your eye. So, this is Dr. Shireen, one of our docs in Suva, doing a test on a lovely Indian lady. In conclusion, let's just wrap it all up because I know some of you got places to go. Avoidable blindness from diabetes comes down to two things: detection of diabetes and screening. That's all we need to know about that. Okay. The problem is that the detection or diagnosis of diabetes is ad hoc and random. Most people in the Pacific are diagnosed secondary to some other acute presentation, whether it's presented to the emergency room with a septic foot, or a sudden loss of vision, or feeling very unwell because their kidney function is absolutely rubbish. So that's really, really common. So nationwide, what they call NCD, so non-communicable disease screening programs, something that every nation needs to consider, and the management and screening of retinopathy. So this is what it looks like in the laser clinic. Lots of bright coloured lights being flashed into the eye. It's not a nice process. It can feel kind of very unusual for patients, especially if you consider the level of understanding about what it is that they've got. What are we doing to them? You know, it can be quite tricky to get adherence and buy-in, and for patients to understand that actually they need to keep engaging and come back. It's not just a once-off like this guy. So he comes, he has a surgery, he does a couple of post-op checks, and then he's out of there. He goes back and lives a normal life. This condition requires ongoing routine screening.